Fundus dystrophies. That's the topic now, and that's the easiest in retina per se. There aren't a lot of concepts in fundus dystrophies, guys. Yes? So what do you mean by a dystrophy? Dystrophy basically means a degeneration without any cause. Yes, we don't know the cause of the degeneration. It's occurring on its own. So what do we mean by fundus dystrophies? A degeneration which is affecting the whole fundus. But what particular area in the fundus, guys? So these are degenerations or dystrophies which affect photoreceptor retinal pigment epithelium, choriocapillaris complex. Meaning, guys? Meaning they are affecting the outer layers of the retina and some part of the choroid. So basically the retinochoroidal junction they are affecting. Am I clear? Now, they affect this part and they lead to rod and cone cell degeneration. Okay? So basically in fundus dystrophies, we are losing vision because the two photoreceptors, rods and cones, are also getting degenerated, which are responsible for the vision. Yes? Am I clear here? Now, the only concept here is about rod cells and cone cells. Very basic physiology. Let's see what I am trying to say. Rods, cones. Now, rods are responsible for which vision, guys? Do they give you color vision or do they give you vision in the dark, everybody? All of us know rod cells are responsible for night vision. Or I can call it scotopic vision. But cones, everybody. Cones are responsible for color vision, which is called as photopic vision. And color vision can actually also be called as day vision. Okay. Now, the only confusion here can be why can color vision be called as day vision? So understand, day vision means sunlight, everybody. Sunlight is made up of colors, Vibgyor. Yes. So if you don't see colors, you don't see in the daylight. So color vision is the same as day vision. Now, because of virtue of the presence of rod cells, where everybody? Where are rod cells present? Rod cells are present at the macula or fovea? No. They are present in the periphery of the retina. We say rods are responsible for the peripheral vision that we get. Okay? As rods are maximum in perifoveal area. Am I clear to everybody? They are maximum in perifoveal area. Fovea gives you the central vision. So perifoveal means the peripheral vision. If I say the same thing about cones, everybody. Cones give you which vision, everybody? Central vision. This we know since our basic anatomy, guys. Macula or fovea consists of cones. Most sensitive part gives us the central vision, as cones are maximum at fovea. Okay, I hope I'm very clear about this simple fact. Yes, so rod cells are giving us night vision or peripheral vision. Cone cells are giving us color vision or central vision. Very easy to remember if you have a tendency to forget. C for cone, C for color, C for central. Done? Now, that means everybody, if there is a lesion, of rods, two things will occur. What will occur, everybody? First of all, the patient will complain of night blindness. Yes, night vision will be lost. Night blindness is known as nyctalopia. All of us have heard this word before, I hope. Yes, night blindness is known as nyctalopia. Secondly, when rod cells have degeneration or any kind of a lesion, there will be peripheral loss of vision. No brainer, guys, I hope. Yes. Similarly, let's see what will occur when there is a lesion of cone cells. Again, two things will occur. Which vision will be lost now, everybody? Central. So I will say the patient will have a central scotoma. Yes. And secondly, the patient will have color or day blindness. Okay. Now, what is day blindness known as? Anybody? Night blindness is known as nyctalopia. Day blindness is known as hemaralopia. This terminology we may not have come across, but just a fact, everybody, you just need to remember the name. Night blindness, day blindness. That's all, guys. Okay. So this is the only concept here. What is the only concept? That when we read a fundus dystrophy, we know that the rod cell and the cone cell can get degenerated. So which cell is getting degenerated, rod or cone? Depending on that, the patient will have presentation. Am I clear to everybody? Now, there are two important words here, everybody, nyctalopia and hemaralopia. We should be aware of what are the causes of nyctalopia. What is the DD when a patient has nyctalopia, and what is the differential diagnosis when the patient has hemaralopia. For that, everybody, we will have a look here. So this is given to you, causes of nyctalopia, causes of hemaralopia. So let's first focus on causes of nyctalopia, night blindness. The mnemonic goes OMG, yes, CRAP, C-R-A-P, O for Oguchi disease, that is a fundus dystrophy which we are going to cover. M for myopia, all of us know in high myopia, it can lead to peripheral loss of vision. Gyrate atrophy, again something which has been covered in the uvea chapter. Congenital stationary night blindness, we will cover here again, everybody. It is a type of fundus dystrophy. Cortical cataract, we should already know this cortical cataract because it is peripheral in location. It causes peripheral loss of vision or nyctalopia. Retinal detachment, we are going to study. Retinitis pigmentosa, we are going to study. Fundus albipunctatus, again we are going to study here. Vitamin A deficiency causes nyctalopia, everybody knows universally as an MBBS student. And then phenothiazine and post-refractive surgery. Please remember this. So OMG, CCRRAAPP. That's the way you remember this. Now, let's focus on the causes of hemaralopia or day blindness, everybody. The mnemonic is CAT, CAT, C3A3T1. That is only a single T. C for cone dystrophy, very easy. C for central cataract like a nuclear cataract or a PSC. As is written here, nuclear cataract or PSC. Then Cohen syndrome. A for achromatopsia. Achromatopsia we have covered in neuro-ophthalmology. Achroma means no color, yes. Aniridia, absence of iris. Albinism. Albinism everybody knows, yes. And then T for trimethadione. So please remember this list, everybody, for the causes of nyctalopia and hemaralopia. Straight question. All of the following are causes, except these are the kind of questions that you will come across, everybody. Okay. Now, using this fundamental that we have studied about rod cells and cone cells, everybody, night blindness, day blindness, peripheral vision, central vision, we will discuss some of the disorders under fundus dystrophies. The first disorder we start with is the most important disorder in fundus dystrophies, that is retinitis pigmentosa. Okay. Retinitis pigmentosa is the most common hereditary fundus dystrophy. This is the most common hereditary fundus dystrophy. Yes. So the first thing that comes into my mind is it is hereditary. If it is inherited, everybody, there has to be the most common mode. Yes. So that's my question first of all. What is the most common mode of inheritance? You already know the options, everybody. What is the answer? Let's try to understand. The answer is autosomal recessive. Autosomal recessive. Okay. Can it be autosomal dominant? Yes, this can also be autosomal dominant. But if it is autosomal dominant, we say it has the best prognosis. Prognosis, everybody understands outcome, visual outcome. Yes. So the best visual outcome is when there is autosomal dominant inheritance. It can also be X-linked recessive, XLR. If it is X-linked recessive, we say these cases will have the worst prognosis. Am I clear to everybody? So it can be inherited in various forms, and on each form there is a simple MCQ associated with it. I hope there is no confusion in this, right guys? Now, after we know this, let me ask you what are the symptoms. When I ask you the symptoms, guys, what is the reverse question you will ask me if you don't know it? The only question that needs to be asked is retinitis pigmentosa a rod dystrophy or is it a cone dystrophy? Am I clear? So let's see what I am writing. To discuss the symptoms, I am writing that retinitis pigmentosa is a rod cone dystrophy. Rod cone dystrophy. Now, if you're wondering, again and again I said rod or cone, now I've written rod, cone, both. Why so confusion? So see everybody, at last both the photoreceptors have to get affected. But initially, preferentially, one of the types of photoreceptor, rod or cone, will get affected, and ultimately the other will get affected. So either I can write rod cone dystrophy or I can write cone rod. You understand what I'm saying? If I've written rod cone, that means preferentially, initially, the cells which are getting affected are rod cells. Cone cells will get affected, but at last. So the symptom will be dependent in this case on rod cell. Am I clear? So we already know the symptom will be nyctalopia. Okay, everybody clear? Then what will be the second thing? Visual field, peripheral visual field loss. Yes, peripheral visual field loss. When the peripheral visual field is lost, what does the patient complain? Patient complains of mid-peripheral superior scotomas. Mid-peripheral superior scotoma. In the superior part, in the mid-periphery. Am I clear to everybody? Self-explanatory. When these scotomas will progress, yes? So understand, first of all, the superior part was lost. Then let's say the temporal, then the inferior, then the nasal. So ultimately, what was formed, everybody? What was formed? A complete ring. Yes or no? So it progresses to form a ring-shaped scotoma, which is also known as donut scotoma. I hope all of you have eaten a donut or seen a donut at least. Yes, guys. So donut is empty in the center, everybody. Yes. So because it is empty in the center, we are trying to say that the center vision is still present, but in the periphery vision is not absent. Obviously, this has been named by somebody comes from the Western countries. If an Indian would have named it, we would have loved to name it Vada scotoma. Yes or no? Vada looks like this. Yes. So a ring-shaped scotoma, basically trying to denote that the central vision is still preserved, but the periphery is lost. Yes. When this will progress more, the whole peripheral vision will be lost. Right, guys? Am I right? So what is the patient coming and telling me? The patient is telling me, sir, the whole periphery I can't see. I can only see through the center. If the patient will describe it, he will say, it seems as if, sir, somebody has kept a tube in front of one of my eyes. Try to imagine now I have a tube in front of one of my eyes. The only thing I can see is the center. I can't see any of the periphery. Yes? So the patient describes that tubular vision as if looking through a tube. Or let's imagine you are standing in a tunnel on a road. Yes? So when you are standing in a tunnel, you can only see through the tunnel in the center. None of the periphery is visible. Yes? So the patient describes that tubular or tunnel vision. I hope I am clear about this. The peripheral vision is being lost, starting from the mid-periphery, a small area, then progressing everybody, only the central vision remains, tubular or tunnel vision. The fundamental is the same, rod cells are being lost. Yes, guys? Now, after the symptoms, I am examining the case. So what are the signs I will be able to see? So what are the signs? Number 1, everybody. Arteriolar attenuation. Arterioles will become very thin. They will almost become closed. Attenuate means to close. Secondly, optic disc will be waxy and pale. It will be waxy, it will be shining, and it would have lost its color. Anybody can correlate why retinitis pigmentosa presents with a waxy pale optic disc. Neuro-ophthalmology, guys, correlate if you can think about it. Optic atrophy. Consecutive optic atrophy, guys. We have read that in consecutive optic atrophy, the optic disc becomes waxy and pale, and consecutive optic atrophy occurs due to diseases of retina. Am I crystal clear here? Yes. So, basically, you are seeing consecutive optic atrophy. And the third sign, almost you can say the diagnostic sign, everybody, is bony spicule pigmentation. Bony spicule pigmentation, which is around the vessels. So I am writing perivascular. Okay, perivascular, around the blood vessels, bony spicule pigmentation. This is the triad of signs we say, everybody. Please remember this triad of signs. As an extra sign, number 4, everybody, only in cases of X-linked recessive retinitis pigmentosa, female carriers. Okay, females will be carriers, obviously. X-linked recessive retinitis pigmentosa, we see a shining reflex at macula, which is known as tapetal reflex. Okay, so this is a specific feature to one specific inherited form of retinitis pigmentosa, otherwise the triad. Okay, let's try to see the image of how a retinitis pigmentosa patient's fundus will look like. So as soon as I see this photograph, the first thing that you notice is pigments scattered around. But where are the pigments scattered around? Are they scattered at the optic disc or the macula? No. So these are pigments in the periphery. So everybody, obviously pigments are there, but in the periphery. So that is making you more certain will affected of the retina. That means it should be a case of retinitis pigmentosa. Secondly, if we try to see carefully, we will also be able to see this blood vessel. Can you see, everybody, the arteriole has been attenuated. Arteriolar attenuation. And if we see the optic disc is not appearing any pink at all. It is completely appearing pale yellowish. So we can see a pale optic disc. Am I clear? So the triad is visible very carefully. But if we see, the diagnostic sign is pigments in the periphery. Bony spicule pigmentation. Retinitis pigmentosa. The name is given so because of the pigmentation which is seen. Yes. Now that we know the signs, everybody, let's move on. And let me ask you, what is the investigation of choice? How will you confirm what is the investigation of choice? Think about it, everybody. We already know all the investigations to be done in a case of a retinal pathology. Will you do an FFA? Is it a vascular disease? No. It is a disease affecting the photoreceptors, rods and cones. That means it has something to do with neural impulse. That means the investigation of choice has to be, if you're thinking like me, you will answer ERG, electroretinography. Retina is producing an impulse. Impulse gets produced A wave by rods and cones. It will not get produced because rods and cones both will ultimately get affected. Am I clear to everybody? As simple as that. Now, after we know the investigation of choice, we have confirmed our diagnosis. What is the treatment? So, the first thing that you need to remember is, in India, we still do not have any treatment. When we diagnose retinitis pigmentosa, sadly, we can only inform the patient that you have retinitis pigmentosa. We can only guide the patient that first of all, you will have problem in night vision, then you will lose your periphery. By the time you come to 40, 50, only central vision will remain, and that will also slowly go away. Does that mean there is no treatment at all? No, there are treatments actually, but not in India. The treatment that is possible is a prosthetic device which is named as Argus 2 retinal prosthesis. Argus 2 retinal prosthesis. Okay? Prosthesis, you understand that we are implanting an artificial retina. But this is for the absolute blind cases, because this restores only central 20-degree vision. So when and if the patient has completely lost the vision, even the central vision, then you can do this. Yes. Thirdly, there is a drug, everybody, which has been approved by the US FDA called as Voretigene Neparvovec. Voretigene Neparvovec. The brand name is this, Luxturna. Okay. Now this is very easy to remember. The name itself is telling you actually what is the function or what is the drug doing. Voretigene. Vo wala, gene. retinitis pigmentosa का. You understand everybody? So वो वाला gene retinitis pigmentosa का, that is mutated and this drug is trying to treat that. वो reti gene. Okay? So this is used if biallelic RPE65 gene mutation. Okay, everybody? So that's a specific gene. If this is mutated, then only you can do this. VORETI gene is a adeno-associated virus vector-based gene therapy. Okay? So the gene needs a vector, everybody. So the adenovirus associated vector-based therapy, and this is VORETI gene, niparvovec. Not going into the details, just remember when it is used and what is the carrier for it. Am I clear? They are very costly treatments. They are still not in India. Maybe in the future they do come to India, but they are also, you understand, reserved for only the end stage cases of retinitis pigmentosa. Done? So that's about the treatment. Now, a question which is frequently asked about retinitis pigmentosa is, what are the systemic associations of retinitis pigmentosa? Okay. So, number one, the most common systemic association, everybody, is Lorentz-Moon-Beidel syndrome. Lorentz-Moon-Beidel syndrome. What occurs in this, everybody? Obviously, we are talking about retinitis pigmentosa. But along with that, the patient will have mental retardation, MR, plus, everybody, the patient will be obese, plus you will notice polydactyly. Am I clear? So this is the complete patient that you will see. So polydactyly means more number of fingers than 5. So maybe a 6 finger, 7 finger thing. Then obese patient, mentally retarded and having retinitis pigmentosa. Secondly, everybody, another important common association is Usher's syndrome. I do hope everybody knows the classic RP plus deafness. Okay. So Usher's syndrome has retinitis pigmentosa. Along with that, the patient has sensory neural hearing loss, or I am calling it deafness simply. Number 3, Refsum disease. Refsum disease patient has retinitis pigmentosa plus cerebellar ataxia plus polyneuropathy. Lastly, another important association is known as Besson-Kornzweig syndrome. This is a very important condition from the point of view of pathology subject. Everybody, I hope you remember this. Retinitis pigmentosa plus A beta lipoproteinemia plus, everybody, now the pathology part. If you remember, acanthocytosis. So these patients, when you will look at the blood picture, everybody will have acanthocytes. Acanthocytes are also known as spur cells, everybody. Okay. So the kind of question that can come is, they can give you a blood picture, everybody, showing acanthocytes. And by that acanthocyte seen in the blood peripheral smear, they will ask you which ocular disease will occur. The ocular disease will be retinitis pigmentosa. I hope I am clear here, everybody. Yes. So that is all about our disease, retinitis pigmentosa. Everything can be remembered if you remember rod cell and cold cell. R for retinitis, R for rod cell. If rod cell problem, nyctalopia. If rod cell problem, peripheral vision loss. Peripheral vision loss means ring, scotoma, tubular vision, tunnel vision. R for ERG, investigation of choice, I can say so. Yes. Are we clear? Pigmentosa. Pigmentosa means bony spicule pigmentation. So everything can be remembered from the name. That is how you need to try and remember. There is a lot of information. How you remember it, that is up to us, everybody. We have to form little tricks in our brain. Right, guys? That's the first fundus dystrophy, retinitis pigmentosa. Let's move on to the second fundus dystrophy, everybody. The second disorder that is important as a fundus dystrophy, the name is Best's macular dystrophy. It is not best macular dystrophy. It is not the best. It is not a good dystrophy. Best's is the name, everybody. Yes, Best's. Okay, done. Now, number 1, what is the mode of inheritance, everybody? Autosomal dominant. Number 2, everybody, what are the symptoms. As soon as I ask you the symptom, I look at the name. The name says it is a macular dystrophy. Macula means center, macula means fovea means cone cell. So the term macular itself is telling you that it has to be a primarily cone dystrophy. If it is primarily a cone dystrophy, I hope we understand it has to be a no-brainer that the patient will have color blindness and day blindness, hemaralopia, and on visual field, the patient will have a central scotoma. So see again everybody a trick. In the name everybody, macula tells you the symptoms. Yes? Now, what are the signs? Number one everybody, there is lipofuscin accumulation. Number two, on examination everybody, we see, so I will say fundus appearance. Fundus appearance is known as having a vitelliform lesion. Vitelliform lesion. Vitelliform is egg yolk like. Okay. What do we mean by egg yolk like? I hope all of you have eaten an egg. If not, then at least seen an egg, guys. So an egg is said to have two parts, the white and the yellow. The yellow in the center, everybody, is known as an egg yolk. So when you look at the fundus in a case of Best dystrophy, everybody, you see as if the egg yolk has been kept on the macula. It's a macular dystrophy. So everything will be seen on the macula. So if I show you the photograph, everybody, I hope you should not have any doubt. If you have any doubt, let's see the anatomy first. This is the optic disc. These are the blood vessels. This is the temporal part. That means this must be my macula. Now on the macula, what do you see everybody? You see a round egg yolk, a half fry, sunny side up everybody. Yes or no? So that's the classic appearance. Egg yolk vitelliform lesions. Am I crystal clear everybody? The image and the name should be very easy for all of us. Yes? Now, apart from this, what else can we see everybody? Number three. After this vitelliform, egg yolk resorbs. It breaks everybody. So try to understand that the half fry you are cutting and the liquid is getting oozed out. So all this liquid gets resorbed and gets collected in the anterior chamber to be given the name pseudohypopaeon. Pseudohypopaeon. Hypopaeon means collection of pus in the anterior chamber. This is not an infective material. We are not discussing an infective condition. So it looks like a hypopaeon, but it is not infective. It is not pus. So we are calling it pseudohypopaeon. This stage is known as vitelliruptive stage. As I explained, the egg yolk has burst, vitelliruptive stage. Am I clear? So these are the three important signs of a case of Best macular dystrophy. One very classic simple photograph to be able to diagnose. Now comes the important point everybody. What is the investigation of choice? If we understand retinitis pigmentosa, we must be thinking again the retinitis pigmentosa ERG. That should be the investigation of choice here. But that is the anomaly you can say. Here the investigation of choice is EOG, not ERG. If you're asking yourself why everybody, then understand that EOG is measured by something called as Ardence ratio. Ardence ratio here is less than 1.50 or 150%. This is a classic case everybody where Ardence ratio is helping us diagnose the disease. The normal was greater than 185, 1.85. Here it is classically less than 1.50. It leaves no doubt in our minds that it is a case of Best macular dystrophy. EOG is absolutely abnormal, but uncharacteristically ERG, which we would have expected to be also abnormal, is absolutely normal. So please remember there is normal ERG with abnormal EOG. If this is what you encounter in a question everybody, this question had come in All India 2011. Straight line was written that on examination a patient has normal ERG with abnormal EOG. Everybody, what is the diagnosis? Okay, so these kind of questions do ask. If this line or such a pattern of question is used, we are sure about the diagnosis here. Am I clear to everybody? So that's our second fundus dystrophy, Best macular dystrophy. Now Let's move on to the third condition here. The third condition is known as Stargardt's disease. If you've seen the neuro-ophthalmology lecture, everybody already, you would have heard this name, Stargardt's disease. All the macular diseases cause blue-yellow color blindness except Stargardt's disease. This was the line. Yes, I hope you remember it. If not, then we are studying it here. Mode of inheritance is autosomal recessive. Then please remember, this is the most common juvenile macular dystrophy. This is the most common juvenile macular dystrophy. So as soon as I'm writing juvenile, you understand the age group we are talking about. Yes, we are talking about teenage, everybody, 10 to 20. Then we have said macular. Again, just like Best's dystrophy, we have written macular. That means it is again which type of dystrophy, everybody? Cone dystrophy. So again, I hope we understand the patient will have hemaralopia and cone dystrophy. Okay, no confusion here. What are the signs now? Number one, everybody. The patient has bull's eye maculopathy. Bull's eye maculopathy. Yes, I'll show you the photograph. Secondly, on FFA, fundus fluorescein angiography, we get a sign which is known as dark choroid sign, or some authors call it silent choroid sign. Dark choroid sign or silent choroid sign. Let's understand both these in a photograph. Let's see the first photograph here, everybody. This is bull's eye maculopathy. Why is it bull's eye maculopathy? Again, I will ask you to focus on the anatomy first. Optic disc, blood vessels, temporal side. That means now I have to focus on the macula. On the macula, if I see carefully, what do I see? I see a central dark ring. Then I see a light ring. And then I again see a dark ring. So my macula has dark and light alternating rings. It looks like a dart game. Yes or no? So in a dart game, if you have ever played, everybody, when you hit in the absolute center, you call it a bullseye hit. Yes or no? So that is why this gets the name bullseye maculopathy, because it is appearing like a dart game, hitting in the center, bullseye. Am I clear? Bullseye maculopathy. No confusion? Now, let's look at the second image, everybody. Image number 2. In the second image, we have to see which sign, everybody, now? Dark choroid sign or silent choroid sign. To understand this, everybody, I will show you the photograph of a normal FFA again. Everybody, this is the normal FFA. In the normal FFA, apart from the dye going into the retinal blood vessels and a dark macula, what do you see? You see that the whole fundus has a background fluorescence. Can I say that there is a background fluorescence? I hope you understand what I am saying. That the whole fundus is shining in a very dull white color. Why is that so? This is so because the dye is also going into the choroidal blood vessels. So the choroidal blood vessels are giving you a background fluorescence due to dye in choroidal vessels. Am I clear, everybody? Now compare the normal FFA photograph to this photograph. Do you see any background fluorescence at all? It's like a blackboard over which we have drawn white lines. That means there is no dye which is going into the choroidal blood vessels, and that is why this sign gets to be known as dark choroid sign or silent choroid sign. No background fluorescence. Am I clear to everybody about this? Yes. So these are the two photographs of a case of Stargardt's disease, bullseye maculopathy and dark choroid sign. Done, guys. That's all about Stargardt's disease. Now that we have finished Stargardt's disease, I hope when you heard the word bull's eye maculopathy, because of the current scenario of COVID, guys, and the whole controversy surrounding chloroquine, hydroxychloroquine, everybody, you got fixated on this word, I hope. Why, everybody? Because one of the ocular side effects of hydroxychloroquine is bullseye maculopathy. So this name can be used and asked a question on chloroquine also. So what we are discussing here is, everybody, the topic is chloroquine toxicity. Chloroquine toxicity. So a stage 1, I can say this is called as the pre-maculopathy stage. In pre-maculopathy stage, we say on stopping the drug, all the changes in the eye will be reversible. There is normal vision, but there is central scotoma. Central scotoma has started to occur, but the macula does not develop any changes as yet. Okay? Now, secondly, everybody, comes maculopathy. In the second stage, now we will see what, everybody? The bullseye lesion. Okay? We will see the bullseye lesion. Now the question is, when do we see the bullseye lesion? When does the maculopathy develop, everybody? If daily dose is greater than 3.5 milligram per kg or 250 milligram in total. Okay? Secondly, if the cumulative dose is greater than 460 milligrams. Thirdly, if the duration of treatment is greater than 5 years, or if there is renal or liver function compromise. In any of these cases, everybody, chloroquine can develop the bullseye lesion. Okay, so please remember the factors which are, you can say, the risk factors for development of bullseye lesion in a chloroquine case. In this case, apart from bullseye, obviously what will occur? Visual acuity is low. Plus, everybody, this is irreversible. So I hope you understand pre-maculopathy versus maculopathy. Pre-maculopathy is reversible, but once this bullseye lesion develops, on stopping or discontinuing chloroquine, this will not be reversed, irreversible. Apart from pre-maculopathy and maculopathy, chloroquine can also lead to vortex keratopathy. Okay, a lot of drugs cause vortex keratopathy. This has been explained in detail in chapter cornea. Okay, everybody, done? So that's a little bit about the hydroxychloroquine given the current scenario of COVID-19 correlation with Stargardt's disease, because both of them have bullseye maculopathy. Please remember this. Done, everybody? Now let's go back to our fundus dystrophies. We have discussed 3 diseases: retinitis pigmentosa, Best's macular dystrophy, and we have discussed what, everybody? We have discussed Stargardt's disease. Now, the next condition that we are reading is a group of disorders actually known as congenital night blindness disorders. From the name itself, it is very clear that these are night blindness disorders and they are congenital. Yes? So basically, I am saying the patient will present with infantile onset nyctalopia. The patient will present with this. An infant, everybody, will have night blindness, congenital night blindness disorders. Now, there are certain diseases which can lead to infantile onset nyctalopia. What are the diseases? We will list, everybody, and we will try to differentiate between them. So, the first disease which causes this is called as congenital stationary night blindness. CSNB. The second disease, Oguchi disease. The third condition, enhanced S-cone syndrome. And then lastly, fundus albipunctatus. Okay. So these are the 4 conditions which can lead to congenital night blindness, infantile onset nyctalopia. How to differentiate these 4 conditions? Based on ERG recording and based on appearance of fundus. Okay, everybody? So congenital stationary night blindness. This is the only disease which has an absolutely normal appearing fundus. Okay? But on recording of ERG, we get a negative ERG. Only negative waves below the baseline. There is no positive wave. Okay, everybody? Then let's move on to Oguchi, enhanced and fundus albipunctatus. In all the 3, the fundus is found to be abnormal. Okay? So how to differentiate between 2, 3 and 4? Based on ERG. In Oguchi disease, ERG is absolutely normal. Okay? In enhanced Escon syndrome, we again get a negative ERG. Whereas in fundus albipunctatus, there are absent rod responses. So there will be no ERG produced under scotopic conditions. Because rod cells are damaged, there are absent rod responses. Am I clear? Now, after we are able to differentiate, the question which you should be asking yourself is, in Oguchi disease, there is night blindness. If there is night blindness, the rod cells should have been affected somewhere. Even if the rod cells are affected, why are we saying the ERG is absolutely normal? See, in all the other 3 cases, congenital stationary night blindness, enhanced Escon syndrome or fundus albipunctatus, because rod cells are affected, ERG has some kind of an abnormality. But not in cases of Oguchi disease. Why? That is the fundamental here. That in Oguchi disease, there is no damage to rod cells. Instead, damage in conduction. So the visual impulse is getting produced, but it is not getting conducted. So there is some problem in the synapse circuits. Okay. That is why Oguchi disease is diagnosed by Mizuo-Nakamura phenomena. This name has been asked as a question thrice in the past 10 years, guys. Mizuo-Nakamura phenomena. What is Mizuo-Nakamura phenomena? That in light conditions, fundus has a golden yellow color. Okay, everybody? What is Mizuo-Nakamura phenomena, everybody? That once light is being thrown, there is light all around you, everybody, and you examine the fundus of the patient. The fundus will have a golden yellow color. But if there is dark all around the patient, everybody, if the patient is sitting in a dark condition, so we are seeing a dark adapted retina, the fundus loses its golden yellow color. Yes, this is known as Mizuo-Nakamura phenomena. Why does it occur? There is no explanation for it. But yes, this is known that there is no problem in rod cells. That is why the ERG is normal. There is problem in conduction of the impulse generated by the rod cells. Am I crystal clear, everybody? That is how we differentiate between causes of infantile onset nyctalopia. Please do focus on the name Mizuo-Nakamura phenomena, Oguchi disease. All these are causes of nyctalopia. Done, everybody? So that's our important condition, congenital stationary night blindness. That finishes our topic apart from certain miscellaneous conditions of fundus dystrophies. Miscellaneous condition number 1, which I am going to discuss with you, is known as X-linked retinoschisis. 2 simple questions about this, everybody. First of all, what is the meaning of the word schisis? Schisis means split. Split, everybody. Something is getting split. What is getting split? Obviously, retina. So there is a split in retina between nerve fiber layer and rest of retina. Am I clear? So the nerve fiber layer is splitting out. The rest of the retina, everybody, is becoming split again. Yes? Now, this presents with, remember this name? Bicycle wheel maculopathy. Straight question can be asked, guys. Bicycle wheel maculopathy. That's it. Then another important miscellaneous disorder that you need to remember, again as a simple question, is Stickler's syndrome. This is also a fundus dystrophy. Why we are mentioning this? Because this is the most common inherited cause of retinal detachment in children. It is a dystrophy of the fundus which causes retinal detachment in children. Most common inherited cause, everybody. So just remember this name, Stickler syndrome. You should have come across this name if this question is ever asked. So 2 simple questions, 1 worded, and 4 important diseases, everybody. Retinitis pigmentosa, remembered from the word R. Best's macular dystrophy, please remember the egg yolk. Please remember EOG abnormal, ERG normal. Stargardt's disease, the bullseye maculopathy photograph we have shown, and the chloroquine that has to be linked along with it. And lastly, congenital stationary night blindness or congenital night blindness disorders. That's a very simple topic, fundus dystrophy. If you understand, there is nothing much to actually understand. There is all to remember, all pieces of information, rods and cones. That is the only thing you can learn, understand. Nyctalopia and Hemaralopia. Right? So that's our third group of disorders done, everybody. We have done the tumor, we have done the macular disorders, we have done the dystrophies. Now we start with our fourth group of disorders. That will be vascular disorders of the retina.